Up until now in this class, we've been talking about basic concepts and principles in health psychology, things like responses to stress, coping techniques, social support, and changing health behaviors. And most of the time, we've talked about these things as if everybody was the same. But everybody's not the same. And it turns out that there are differences in health based not only on gender, but also ethnicity, socioeconomic status, and age. In this video, I'll talk mainly about gender differences in health, with a bit about age at the end. We'll begin with a very interesting question. Which is the healthier sex? Well, this is quite a puzzling question, so we're going to look closely at the data to answer this question. First, we'll look at mortality data, and then we'll look at morbidity data. So when considering mortality and morbidity data, there are multiple ways to consider this information. For mortality, we can look at lifespan, death rates, and causes of death. For morbidity, we can look at disability, hospital usage, and physician visits. If you compare males and females on lifespan, females always have an advantage. They always appear to be healthier. Females have a longer lifespan than males by approximately 5 years, with women living to be about 81.3 years and men living to be about 76.2 years old. However, this gap has been decreasing, with men catching up to women. Researchers believe that this is because men are smoking less than they have in the past. Men are also less likely to be obese than women, and additionally, men are more likely to go in for treatment for hypertension and high cholesterol. With this in mind, let's look at death rates across the lifespan. At every age in the life cycle, fewer females die than males. Fewer females even die in utero than males. For every 125 male fetuses that are conceived, only 100 female fetuses are conceived. But birth rates are essentially identical. And then, at every age bracket, more males die than females. Here are the stats for the number of deaths in 2005. This is the rate per 100,000 people. So the death rates for males are always higher than the death rates for females. These are the ages for up to 34 years old. Here are the rates for ages from 35 to 74. Again, you can see that females always have a lower death rate. And here are the final rates for up to ages 75 plus. Again, females always have a lower rate of death than men. In a little while, we'll talk about why these rates vary so much across the lifespan. But for now, all we need to do is focus on the fact that at every age bracket, more males die than females. In the 1980s, for each of the 12 leading causes of death, more men died than women. This has changed a lot since then, but more men still die than women from the big two causes of death, heart disease and cancers. Again, these numbers reflect deaths per 100,000 people. Here's a chart of the 10 leading causes of death in the United States from 2010. I've listed the death rates for males, for females, and the ratio of male death rates to female death rates. If the ratio is larger than 1, that means more males die of that disease than females. And if it's less than 1, then more females die from that disease than males. The color of the line is who's healthier when it comes to that disease. So you can see you're better off being a female when it comes to heart disease, cancers, accidents, diabetes, kidney disease, and suicide. So in general, what you find when you look at all the death indicators is that females are healthier than males. They live longer, fewer die at every age, and they're less likely to die of the two leading causes of death. It's because of this sort of data that there exists this stereotype in the medical community that women are the healthier sex and they're less likely to be diagnosed with major diseases. We'll talk in a little while about some of the implications of this. There are lots of ways to measure health, and measures of mortality are just a subset of them. Now, let's consider morbidity rates, measures of sickness and disability. This table shows some morbidity indicators and sex ratios of them. As you can see, women have more restricted days of activity, more bed disability days, and more work loss days than men. So on these measures, it looks like men are healthier than women. So if you look at morbidity measures, men are healthier. How can we reconcile this data on morbidity and mortality? In general, when we look at the data on morbidity and mortality, it becomes clear that it's kind of ridiculous to try to answer the question, who's healthier, males or females? The best way to answer this question is probably the same as the answer to the question of who's smarter, males or females. The only reasonable way to answer this question is which male are you talking about and which female are you talking about? But what's clear from these data is that males and females have different patterns of health and illness. In general, it appears that women are more frequently ill, but they suffer from things that aren't life-threatening. So things that lead to symptoms, disability, and medical care, but not death. Men, however, are sick less often, but when they are sick, their illnesses and injuries are more severe, and they have higher rates of many, but not all, of the leading causes of death. The real question is, why are there these differences in health patterns between males and females? So why do women live longer than men? Well, for one thing, men take more unnecessary risks. Evolutionary psychologists claim that this is because risk-taking is a means for men to acquire status and to attract mates. They suggest that the fact that males' tendency to take dangerous risks, including getting into physical altercations, peaks at the very time in their lives at which they should strive most to acquire mates and vie for high status, late adolescence and early adulthood. They call this phenomenon young male syndrome. Young male syndrome is no joke. Based on the data I showed you in the previous slides, between the ages of 15 and 24, 2.76 males die for every one female. I'm just speculating here, but these excess deaths probably aren't due to heart disease or diabetes. So if you or someone you know suffers from young male syndrome, please make sure to keep a camera handy to improve your chances of capturing hilarious footage. That's really the best advice I can provide. I'm more than a little pessimistic that we'll ever be able to combat young males' tendency to do stupid things to impress their peers. With that public service announcement out of the way, there are 4 other broad types of explanations to explain why males die younger than females, with somewhat arbitrary distinctions between some of them. So these explanations have been categorized more for ease of discussion than because of meaningful distinctions between them. These are biology, health behaviors, utilization of the medical system, and social support, stress, and social roles. First, females are biologically advantaged. The best evidence for this is that more male babies die in utero than females. It's hard to explain this finding without pointing to some biological difference, because in utero, people probably aren't treating their boy babies differently from their girl babies. In most cases, people don't yet know the sex of their child at the point when miscarriages are most likely. So during the first trimester, a lot of women don't even know that they're pregnant when they miscarry, and half of all miscarriages happen during this first trimester. So it's hard to blame this on anything other than biology. Any differences in health that are based on different amounts of or types of hormones in the system are also generally attributed to biology. For example, differences due to protective effects of estrogen are biological. In addition, testosterone has often been likened to a poison. It damages the body and leads people to make rash decisions. Also, differences might occur because lots of information that can lead to abnormal development is carried on a recessive X chromosome. For females, that information is suppressed by their other X chromosome, their dominant one, But for males, this abnormal information is more likely to be expressed because they don't have a second X chromosome to dominate it. So males end up with more conditions such as hemophilia, meningitis, muscular dystrophy, and mental retardation. So biological explanations can account for some of the differences in health between males and females. Another type of explanation for differences between males and females in their health is that males and females engage in different amounts and different types of risky and protective health behaviors. As we've talked about in this class at length, most diseases that people die from these days are associated with the behaviors they engage in. If you look at the age brackets where males and females are most different in terms of their mortality, you find that those are the ages where something unusual has to happen if a person's going to die. People are generally healthy at these ages. The difference between the male and female death rates at these ages probably has a lot to do with their health behaviors. Things like alcohol and drug use, reckless driving, and violence are things that males almost universally do more often than females. So these behaviors seem to be driving the male-female health difference here. Insurance companies highlight this difference. Car insurance is much higher for a 16-year-old boy than a 16-year-old girl, and insurance remains higher for men for quite a while. These differences aren't because health insurance companies are trying to be nicer to women. They have these rates because men engage in more dangerous, unhealthy behaviors that might cause a car crash. So different patterns of health behaviors can also lead to different health outcomes for males and females. Difference in healthcare utilization is another example for differences between the health of men and women. This is usually lumped under health behaviors, but it really deserves its own special place. Men tend to use the healthcare system less often than women. So men tend to have a lower frequency of physician office visits than women. They're less likely to have yearly checkups, and they're less likely to participate in routine preventative screenings. Because males use the medical system less often than women, they're more likely to catch an illness later on in its course, which can sometimes make the illness more difficult to treat. This is a graph of physician contacts for males and females across their lifespans. And as you can see, the male line, that solid line, is always lower on the graph than the two female lines, at least after childhood. That says that men have fewer doctor visits than women. There are two lines for women. The lower of the two excludes visits regarding pregnancy and birth control. And even after controlling for reproduction-related visits, the male line is still lower than both female lines. There are a lot of possible reasons why males use the medical system less than females. First, they may not want to admit to being sick. Basically, it's not considered masculine to say that you're not feeling well. In addition, males may be less likely to notice their symptoms of illness. And there is some evidence suggesting that women are more likely to notice their symptoms of illness than men. Men may also not want to take time off work to see a doctor, or may be less able to take time off work to see a doctor. Also, females are strongly encouraged to have yearly gynecological exams, whereas males are not as frequently urged to have regular yearly checkups. Finally, females may come into contact with doctors while taking care of children, or elderly people, and oftentimes they may come away from these contacts with a little advice for themselves or a referral to see another healthcare provider. All these differences might lead females to see doctors more often than males, which may cause them to remain healthier. It may prevent them from getting these big diseases. A final category of explanations for differences in males and females' health patterns is social support, stress, and social roles. However, the direction that these factors point to is unclear and leads to a lot of controversy. If men and women differ in the amount of stress that they feel, this could lead to different health outcomes, but it's not clear which gender is more stressed. In many studies, women do report more stress than men, and they do have higher rates of depression and anxiety. In other studies, males report more stress, and in these studies, this stress is attributed to being in the workforce. But many studies of women show that working is beneficial to their health. So there are competing theories about whether working is helpful or harmful for both men and women's health. In terms of coping, studies generally find that women engage in healthier coping techniques. They're less likely to use avoidance coping than men, and more likely to seek out and make use of social support. So all these factors affect health in different ways, although it's not clear what the result of all these factors is. The picture that emerges from these different explanations for differences between men's and women's health is that the situation is very complicated. There are an enormous number of factors that interact to affect people's health, and I've barely scratched the surface here. But the problem that remains is that despite this complex picture, the health of men remains the standard, and women's health is thought in terms of being in comparison to this standard. In the 1970s, pregnant women were sometimes given a drug called thalidomide for nausea. Unfortunately, it turned out that thalidomide caused babies to be born with severe birth defects. Due to this, starting in the 1970s, women of childbearing age were excluded from all the early stages of medical research. And the point of this was to protect women and fetuses. And being protected is good, but they kind of went overboard and banned all women of childbearing age from these studies. Even if they weren't pregnant, not trying to get pregnant, not sexually active, or not even able to get pregnant. And to me, this shows a certain lack of respect for women's autonomy and decision-making abilities. The end result of all this, anyways, is a huge gap about our knowledge about women's health issues. Females are also harder to study because their hormone levels fluctuate across the month due to their menstrual cycle. Furthermore, females are harder to include in studies because they sometimes change their name when they get married, leading researchers to lose track of them, or they're solely in charge of the care of their children, so the study has to offer childcare, which is expensive for researchers. In JAMA, which is the journal of the American Medical Association, basically the top-tier medical journal, in the 1990s, 74% of articles on diseases that both males and females get included only males, and women were excluded from a large proportion of the stress literature, which is why researchers are only now starting to realize that women may have very different stress responses than men. In 1993, Bill Clinton signed the NIH Revitalization Act, which required that in all research funded by the NIH, women must be included in the samples. That's great for all the government-funded research, but does nothing for industry-funded trials like those conducted to test most drugs. Things are better than they once were, but they're still not great. Female participation in clinical trials is still rather low. One group of researchers looked at clinical trials from 1994 to 1999 and found that in 120 trials, on average, only 24.6 women were in these studies. Gender-specific analyses were conducted in only 14% of these trials. In the 46 largest clinical trials completed in 2004, women made up less than 25% of the subjects. In one recent study, researchers looked at every animal study published in 2009 and found that there was a bias toward using male animals in 8 out of 10 specialties. For example, neuroscientists used 5.5 times as many females as males, pharmacologists used 5 times as many, and physiologists used 3.7 times as many. So at least having women in government-sponsored research is a good thing, and those studies do have more balanced samples. But researchers still need to analyze their data separately for males and females and ask questions that are specific to women. Basically, just make women's issues part of their agenda. So, for example, in the 1990s, researchers started including females in HIV studies, but they just kind of tossed these women into these studies. They didn't ask questions that were specific to women. They didn't ask anything about the effects of HIV on gynecological problems, for example. So we're still behind in our knowledge of the effects of HIV on women's health. We're also way behind in our knowledge of what to do when pregnant women get sick. This is partly because of the thalidomide scare I mentioned earlier, which led women of childbearing age to be excluded from research. There are no longer across-the-board bans like this, but still, most studies in the 90s and 2000s required the women in them to be on contraception or to be sterile or infertile. So, we now know very little about what drugs are safe for pregnant women to use. We don't know what treatments they can safely use. We're not sure if it's safe for them to take antidepressants, although 1 in 8 pregnant women do take antidepressants. But pregnant women have been excluded from clinical trials on antidepressants. So we have no idea how these women are being affected by these drugs. One way we can study this ethically is to have trials of the effects of drugs, such as antidepressants, among pregnant women who are going to be taking these drugs during their pregnancy, whether or not they were going to be in a study. In addition, one researcher looked at the 8 most commonly used medical textbooks and found that the illustrations were 64% male, 11% female, and 25% no gender. So just a hand or an ear or something like that. The problem here is that doctors aren't being trained to be very familiar with the female body. So it does seem that men's health is the standard. Unfortunately, there are repercussions for this. One consequence is that certain illnesses in women are noticed later in women than they should be. For example, heart disease is considered a male disease, even though it's the leading killer of women in this country. But despite this, it's still considered a man's disease. A 1999 study of 720 primary care physicians found that the physicians would refer women to heart specialists only 60% as often as they would refer men with identical symptoms. Another study found that in a group of patients who had taken specialized tests that showed evidence for heart disease, 40% of the men, but only 4% of the women, were referred for the next test to see if coronary artery surgery was necessary. Women had the same symptoms as the men and the same abnormal test results, but they weren't referred to more tests because perhaps doctors just don't think of women as having heart disease. Because these symptoms tend to be ignored in women, by the time women are referred for coronary artery surgery, they're older and sicker than men would be when referred for the same surgery. And it turns out that women are twice as likely as men to die from these kinds of surgeries. Another consequence is that health patterns in women that differ from health patterns in men are considered problematic solely because they're different. For example, when men's blood sugar was considered the standard, it was thought that millions of women had low blood sugar, hypoglycemia. It turns out that women's blood sugar on average is simply just lower than men's blood sugar, and it's perfectly healthy. It's not a problem. But it leads doctors to pathologize women's perfectly acceptable health patterns. Another consequence is that things that are unhealthy in men are assumed to be unhealthy in women, despite evidence to the contrary. For example, overweight women aren't at a health risk to the extent that overweight men are. Lots of research shows that what matters isn't how much excess weight one is carrying, but where that excess weight is being stored. Women tend to store their excess weight in a pear pattern around their hips, thighs, and butt, whereas men tend to store their excess weight in their waist and gut in an apple pattern. And it's the apple pattern that's linked to poor health outcomes, not the pear pattern. Another consequence is that drugs are tested on men, not women, leading to lower efficacy in women and more side effects. Drug doses are designed with males in mind. For example, women receive 70% of the prescriptions for antidepressants, but most of the studies testing antidepressants were conducted on men, with just a few studies looking at how males and females differ. Because of that, antidepressants work better on men and cause fewer side effects in men. Similarly, women require only half as much flu vaccine as men to get the same level of protection, but they're always given the same amount. This issue of differences in side effects isn't trivial either. 8 out of 10 prescription drugs pulled from the market in 1997 to 2001 had more side effects in women than men. This testing issue doesn't just include drugs, but it also includes the creation and testing of new surgical techniques, the creation of devices to use in surgery, vaccines, diagnostic equipment, and diagnostic criteria. The following film clip investigates this last point in more detail.
Early last year, the FDA made a surprising announcement. It cut the recommended dose of the nation's most popular sleep drug, Ambien, by half, but only for women. Lester Stahl learned how much different men and women are when it comes to medicine. Here's a preview of her report for Sunday night 60 Minutes.
We have generated just a ton of information that suggests that there's sex differences everywhere.
Larry Cahill, a neuroscientist at the University of California, Irvine, used to share his field's assumption that males and females outside the reproductive system were fundamentally the same. But he's changed his outlook 180 degrees. Ambien, he says, is a case in point.
Ambien, prescribed 40 million times just last year. Approved 20 years ago. We're only now finding out that women have been prescribed a dose that's twice as high as they need.
That is a textbook example of what's wrong. How did it happen that for 20-some years, women, millions of them, were essentially overdosing on Ambien?
The FDA says it made the change after new driving simulation studies established what amount of Ambien or Zolpidem in the blood the next morning could be dangerous for driving. Dr. Sandra Queter, Deputy Director of the FDA's Office of New Drugs, says only then did they realize women could be taking too much, since women metabolize the drug differently than men.
So if I took Zolpidem and my brother took the same dose, probably the maximum level of drug in my blood would be 45% higher than his maximum blood level.
Now that sounds substantial.
It is substantial.
If science got Ambien so wrong, does that tell you that we really need to go back and review
Yes.
what, everything?
Pretty much everything, yeah. Is once you see this difference, and that difference, and that difference, and that difference, and that difference, and you see this thing's everywhere, you go, wait a minute. So the assumption we're making that it really doesn't matter, sex, is not a valid assumption. It may not matter. It may matter hugely. It may flip your results on their head, and you don't know. So what happens is you start to realize, wow, the status quo is not okay. The way we're doing business has to change.
Lester Stahl is with us. Good morning.
Morning, Charlie.
So this is interesting. What surprised you most of all the things that you found out?
I guess what the big thing is how pervasive the differences between men and women are. It's not just that we metabolize medicine differently. Our lungs are different. Our cells are different. Our skin is different. We used to think it was just, you know, the gynecology areas, the bikini medicine, as they called it. But now we're learning that we are pervasively different at every level.
Why didn't we know this before?
You know, that's a great question, because research, and it still is this way, research is done originally on animals, and they use only male animals to this day. Now, they used to only have male in the human studies, but now they have females in the human studies. However, instead of seeing how women react versus how men react in the study, they put them all together and take the average.
You know, Leslie, I remember when Dr. Bernadine Healy took over the NIH, and she said, what, all our taxpayer money, we're only doing tests on males? This is in the 1990s that they first started including
Can you believe
women.
We haven't figured out that if you put the women in, you should be looking at them separately.
Right.
They don't.
And it even includes, in your point, aspirin. We're all told, Dr. David Agus is here very frequently and tells us to take an aspirin every night at bed. That affects men and women differently, right?
What Larry Cahill just said is, we don't know.
Yeah.
And the FDA says they are not going to go back and look at all the other drugs. They're going to go back and look at other sleeping medications, but not everything else that's on the shelf right now. And you think about how much that would cost. Think about how many medications. I mean,
go ahead.
Leslie, if we metabolize Ambien differently, do we metabolize statins differently? I mean, the list could go on and on because men and women are taking the same amount when it comes to Lipitor and other pills.
We don't know.
And we may be
that's why
taking,
Larry Cahill says we should look,
And
but they're not going
But
to.
why wouldn't they? That's the thing. Why
Because
wouldn't they
it's
go
too
back?
expensive. It's ridiculous how many medications are on the market. I mean, it's not just statins, it's antidepressants, it's everything.
and men may be taking too little.
Exactly. Exactly, because they take the average. So, you know, it's big. And the differences, as I say, are everywhere. They're finding our hearts, well, we know heart attacks are different. Lungs are different. Skin is different.
But can you imagine some kind of pressure developing for forcing the FDA to go ahead with more change? Yeah.
We'll just try to think about, I have no idea how many medications there are in the market, but there's a medicine for every organ and every disease. It would be.
You would think also that there might be a market incentive for drug companies, though, to do this, because then they could market more, this is a drug specifically for women, and this is a drug specifically for men.
From now on, from this point forward, they will insist on separate, for the FDA will insist, for future drugs.
We'll get people talking.
Yeah.
And one final example of this male bias is the design of seatbelts. Seatbelts are tailored for man-sized people in terms of height and preferred seating posture, so seatbelts don't work as well for women. They don't protect women as well in car crashes. A study published in 2011 found that female drivers wearing seatbelts were more likely to be injured in car crashes than male drivers in seatbelts, and that belted female drivers had more chest and spine injuries than belted male drivers in comparable crashes. Okay, moving on to age and health. We're going to spend just a little time here talking about issues of aging and health. But first, take a moment to consider how you think about the average aging person. The following clip may challenge some of the stereotypes you may have generated.
Old people. Marginalized. They're not even in the key demo.
I think that's bullshit.
Now,
say big boobs.
They're fighting back.
Take my picture! Take my picture!
With the help of some hidden cameras.
Come back here!
And Betty White.
Off the Rockers team, what have you got?
Young people.
Oh my God!
You've been warned.
Stop staring at my tits, you pervert. Welcome to Off Their Rockers. What I love is all our senior moments are funny and on purpose.
I'm trying to hide from my wife.
Jim!
Dear,
Don't ever talk to me that again.
Do you know anything about cantaloupe?
Yeah.
Yes! Do you see a blue Mustang? Yes, sir. Can you help me? Are you getting ready to drive this car? I got it here. You might want to back away. Corner pocket.
My goodness.
Excuse me.
Oh,
Are those my balloons?
Are you Sandy?
I sure am.
Just a minute. I have to get this phone call. Sorry.
I can't.
My boyfriend just sent me a text about things he wants to do in bed, and I don't know what any of them mean. Do you know what a Boston Tea Party is?
I don't.
How about a Connie Francis?
Connie Francis?
A bagel hole?
What is it? I don't know. I know rusty trombone.
What is that?
I think it's.
Can I get a cold Sprite now?
Okay.
I'll take a cold Sprite.
Okay.
Do you have a cold Sprite?
Yes.
Can I get a cold Sprite?
Yes.
Can you go get the cold Sprite?
Yes.
Can you get it now? Go get it.
Sleepy.
Quick, miss.
My old lady, you know, I got a hotel room and we're gonna really party. You know? She's still hot, you know, after all these years. You know what I mean? I mean, we still, you know, can boom, boom, boom. You know what I mean? We can still. Oh, hey, how are you?
Watch out. If they're gray, get out of their way.
Move the hell out the way, ass clown!
God bless you.
Betty White hosts Off Their Rockers.
The saying is respect your elders. There's nothing in there about us respecting you back.
So what in the world did that video have to do with aging and health? Well, absolutely nothing. I just wanted to wake you up. No, not really. There's actually a point to it. The pranks in that clip are funny because of the stereotypes we have of old people. These pranks are breaking these stereotypes or exploiting them in funny ways. And what we're going to talk about for the rest of this video is that these stereotypes have an effect on the health of the elderly. So obviously our culture has a lot of stereotypes about aging. Old people are considered senile, dependent, diseased, debilitated, helpless, cranky, etc. And research shows that believing these stereotypes is actually harmful to our health as we age. Although we do tend to have a few positive stereotypes of the elderly, such as wise, accomplished, and astute, they're far outweighed by negative ones. It appears that negative stereotypes about aging are pervasive in our culture and exist even in childhood. Children shown pictures of a series of men give the most negative descriptions to the oldest man. In a survey of kids aged 4 to 7, 66% said they would prefer not to become old. These stereotypes tend to be reinforced by repeated exposure, and people seem to be highly susceptible to internalizing these stereotypes. Research on the unconscious operation of stereotypes shows that aging elicits more negative attitudes and associations than any other stigmatized group based on ethnicity, culture, or sexual orientation. In addition, stereotypes about aging seem to be even stronger than people's own experiences with old people. For example, when younger workers have regular contact with highly effective older workers, they still tend to cling to the stereotype that older workers are less productive than younger ones. As another example, it's been shown that nursing home workers tend to use baby talk in addressing residents in a nursing home, regardless of the cognitive functioning of the particular residents. So people have negative stereotypes about aging when they're young, but when they get older, they continue to believe these stereotypes. Essentially, old people become self-stereotypes. In fact, old people express attitudes toward other old people that are just as negative as the attitudes that young people express toward old people. One of the strongest findings in all of social psychology is a preference for one's own group, but this isn't found for old people. There are many repercussions of internalizing these negative stereotypes of aging. The studies on this can be divided into 4 groups: cross-cultural studies, field studies, experimental studies, and longitudinal studies. In cross-cultural studies, researchers look at people from cultures that don't have strongly negative stereotypes about aging, and then compare old people there, on some outcome, to old people who live in the US. In one study, researchers compared memory performance in old people from 3 cultures. These cultures were mainland China, where people tend to have the most positive stereotypes about aging, the deaf community in America, where people have a middle sort of stereotype about aging, and hearing people in America, in which people have the most negative aging stereotypes. They found that the memory performance of their participants mirrored their culture's view toward old people. So in China, where views of aging were most positive, old people did the best on the memory tests. In Deaf America, they performed somewhere in the middle, and in Hearing America, they performed the worst. So this kind of study suggests that holding negative stereotypes about aging can influence the cognitive functioning of old people. But this is a correlational study, so it's still possible that somehow better memory performance in certain cultures caused the different stereotypes to exist in these cultures. This is the reverse causality explanation. In another clever correlational field study, researchers went into hair salons and compared women who had their gray hair dyed to women who had their hair cut and styled but not dyed to cover their gray. They thought the women who had their gray covered would perceive themselves as looking younger and might then show other changes associated with being young. Women who covered their gray hair and who perceived themselves as looking younger after their hair appointment did show other changes. They had decreases in systolic and diastolic blood pressure, and they were perceived as looking younger to independent observers who saw pictures of them with their hair cropped out. Importantly, they didn't see themselves as more attractive, nor were they more satisfied with their hair. Possible alternative explanations of these findings. Experimental studies try to get past the problems of correlational studies by randomly assigning people to be primed with either positive or negative stereotypes of aging. So, some old people in these studies were subliminally primed on a computer screen with positive aging stereotypes, so with words like wisdom, accomplished, or astute, and others were primed with negative aging stereotypes, so with words like decrepit, senile, or diseased. And then these researchers measured various outcome variables. They found that being primed with the negative words led the old participants to perform worse on memory tasks than the old participants primed with positive words. They also found that being primed with the negative words led the participants to walk slower than those primed with the positive words. Being primed with negative aging stereotypes also led people to report that they'd be less likely to accept life-prolonging medical treatments in various scenarios that they read about. And finally, priming negative stereotypes led to a larger cardiovascular stress response to a stressful task compared to people primed with the positive stereotypes. This is just a reminder of a study we talked about during the first week of class. In this study, the researchers simply asked people how they felt about aging and then followed them over time. They did several studies like this. In one, they found that people with negative stereotypes of aging in 1975 did worse on hearing tests in 1998 than their participants who had more positive views of aging. In a second study, the researchers found that the subjects who had a negative view of aging in 1975 were less likely to engage in preventative health behaviors in 1998 than those who had a more positive view of aging. They also found that those who had a negative view of aging in 1975 died 7 years earlier than participants who had a more positive view of aging. This work suggests that the beliefs we have about aging can have profound implications for our health.